welcome to VIVA Unscripted. My name is John Kaufman. I'm the moderator, and I'm very pleased to be here with our two Vascular Career Advancement Award winners, Daniela Branzan from Leipzig, Germany, and Ehrin Armstrong from Denver, Colorado. We'll have just a nice informal discussion. So first of all, congratulations to both of you, both two very accomplished individuals with a lot to do in the future. Just why don't you introduce yourselves and just tell us a little bit about your background.
Well, thank you a lot for the introduction. My name is Daniela Branzan. I'm a senior vascular surgeon, for the moment working in Leipzig at the University Hospital, together with Professor Schreiner and Erin Smith. Well, I started my career approximately 10 years ago in Bad Krozingen with Professor Zeller, also well-known interventionalist. After finishing my fellowship there, then I got the senior position as a vascular surgeon in Leipzig. I do endo work as well as open peripheral work, but my topic of interest is the treating aortic complex aortic pathologies. I start a research in preventing spinal cord ischemia, and I think that is my topic.
Right. Yeah, you've done some very innovative work with different approaches, a little different than the spinal cooling, things like that, but the actually coiling of spinal arteries or lumbar arteries in order to protect the cord?
Yeah, that's right. This is a very, I think, disruptive idea. We start to occlude vessel in order to prevent ischemia. In fact, it's a preconditioning process that we are inducing, and we have some preliminary results that are very, very promising. And I hope that next year I can show you our data.
Right. Well, yeah, we will look forward to hearing it because it is a very counterintuitive, right? You're blocking the arteries that normally you want to keep open. So, right. So Erin, just tell us a little bit about yourself and.
Yeah, thanks very much. So I'm an interventional cardiologist by training, but I had the good fortune during the last year of my training to work with John Laird at UC Davis, and really became very passionate about the care of patients with vascular disease. And so for the last 5 years, I've been over at the University of Colorado and the Denver VA Medical Center in Denver, Colorado. I run the cath lab there and also direct the vascular lab as well. And the majority of my clinical work is focused on patients with advanced peripheral artery disease. I do carotid stenting, EVARs, treat patients with claudication, but my real passion is patients with critical limb ischemia. I work very closely at our hospital in a multidisciplinary fashion with podiatrists and wound care to really advance the care of veterans with critical limb ischemia using advanced endovascular techniques. And so my research interests include observational and trial research related to improving both the medical therapy and the endovascular care of patients with critical limb ischemia.
Right. And you've had some additional training in research, correct?
Yeah, that's right. I did also complete during my training an additional master's degree in clinical research, and so I have a fairly strong statistics and clinical research background. So I've leveraged that in multiple ways. When I was at UC Davis, we did establish a large registry of patients undergoing endovascular intervention, which has, I think, been a really rich source of understanding contemporary outcomes of both medical and endovascular therapy for PAD. And I, in the last few years, have increasingly been working with large registry research, including the NCDR, ACC. I'm on the steering committee of the peripheral vascular intervention modules, and recently have been completing the data upgrade so that we capture the full spectrum of vascular procedures.
Right, and the VA population, very important population, and a really great population to work with.
Yeah, that's absolutely true. I mean, veterans are some of the greatest patients. They put their lives potentially on the line for our country. They're some of the most stubborn people in the world as far as coming in with critical limb ischemia or other problems, but also some of the greatest and altruistic patients. And so I think it's chilling to think that actually the number of people that lose a limb in the United States every year for ischemic causes is greater than the number of amputations as a result of trauma from wars, all combined. So I think there's really a lot of ways that we can do better and improve the outcomes of patients with CLI.
Yeah, so yeah, huge issue, and I think a lot of what VIVA is about is this overall view of improving outcomes in CLI, not just the procedures, which you've kind of talked about. So before this, we were having a little discussion, and an interesting discussion about training. So you're both at the end of your career, which is at the beginning end, as opposed to myself, where I'm more at the tail end. And it might be interesting for people to hear just some of the differences in how training happens both in Europe and the United States. So, Daniela, you were particularly kind of interested in that.
Well, thank you for the question. In fact, I started my training as a vascular surgeon, and as I saw the boundaries of the classical surgical techniques. So, and my mentors, they kind of showed me, look, you can do only so much with open surgery. So I was thinking of getting the endovascular skills, and in Germany that's possible only by joining by that time it was possible only by joining an interventional discipline like the angiology. So I was kind of new in the training for a vascular surgeon to join a endovascular unit. So I asked Thomas Zeller, could I join your department for doing that, and why not? So it was unique for me as a vascular surgeon to work with the endovascular team. It was 1 year of continuous endovascular work that helped me a lot, I can say. And after that, I wanted to also to finish my vascular surgery fellowship, so I kind of combined endo and vascular, open vascular techniques for like 4 years. I was 6 months doing open, 6 months endo for the first two years, and then just doing both of them integrated, like the same day doing a SFA occlusion, and in the morning and in the afternoon having a below the knee bypass. So quite interesting, and I think that helped me a lot. And the things started to change in Germany. So the classical vascular surgeon realizes the importance of endo technique, and now it is not. We don't have a separate training as a vascular surgeon. You have access, and you have to learn the endo technique, and the name of the society also changed in Europe. It's Society of Vascular Endovascular Surgery, and in fact it's not surgeries, but it's medicine.
So
altogether.
You really kind of had to make your own way, though. It sounds like you had to find and even change countries and change languages. A very impressive achievement.
Thank you. It was not straightforward, but I think it was worth doing that. And now I'm happy to be able to cover the full spectrum of vascular medicine, beginning from the medical therapy and going through below the knee bypasses and hybrid procedure, like combining classical surgical technique, common femoral endarterectomy, distal origin bypass with recanalization technique, because we have a lot of very complicated CLI patients caused by multi-level disease, where only one technique it's not enough to treat those patients.
Very powerful concept, bringing together different skill sets and techniques, and not just having everything being a nail because you like to use a hammer. All you know how to use is the hammer, right?
But in all those concepts, I think the teamwork it's the most important. You cannot do by yourself just one discipline to treat this important disease. I think you need to discuss all the patient, and you need to involve every member of the team.
So, Erin, cardiology has a very complex training in the United States. It's first 3 years of medicine, 3 years of cardiology, interventional cardiology, and then it sounds like you went on to work with John Laird. So kind of a difference in the pathway here.
Yeah, I think that's absolutely true. I think cardiology is a specialty in the U.S., and interventional cardiology, we clearly learn a lot about cardiovascular disease from a pathophysiologic standpoint, but the reality is most cardiologists and interventional cardiologists remain primarily focused on the heart specifically. And I think that during interventional cardiology training nationally, many people get exposure to some vascular interventions, but I think the difficulty there is that it's often relatively haphazard and part of the training process that's also combined with coronary and structural interventions. So I think as a result, there are a number of people in the specialty who have some familiarity with vascular disease, perhaps treating relatively straightforward iliac disease or SFA disease, and some of the cognitive knowledge. But I think, honestly, to be committed to the vascular space as a cardiologist, I think it's very important to spend additional time in training, probably at least a year, with someone who focuses on the area as a primary part of their specialty. And I think that's important because there are clearly a lot of differences and subtleties in the management of patients with vascular disease. And there are some other mechanisms to formalize that process that includes board certification in vascular medicine through the American Board of Vascular Medicine and RPVI training as well, both of which I completed. So I think that as a specialty, we need to do better formalizing some of that process, and a lot of the training pathways are beginning to coalesce towards a single year of interventional cardiology focused on coronary interventions, and then differentiation into perhaps structural focused interventional cardiologists as compared to vascular focused interventional cardiologists. And it may become eventually that there are additional formalized years of training like that. But I think currently the majority of the way that that's completed is by working specifically with someone with a focus in that area. And certainly after formal training pathways, I think there are a lot of ways to go to additional courses or work in other facilities in order to get that specific training.
So do either of you think we'll ever get to a point where it doesn't matter where you start? If you want to do vascular, primarily you would end up in a common training pathway next to a vascular surgeon, next to a cardiologist, interventional radiologist, vascular medicine specialist. Think we'll ever be able to get there? Or are we still kind of stuck in our sort of tribal silos a little bit?
Well, 10 years ago, I was skeptic about that because when I started, it was pretty difficult. And I think that it has changed a lot. And now you can see a lot of disciplines working together, like here, VIVA. I see you're a radiologist, cardiologist, me vascular surgery. So look here, we are the three of us from the three disciplines talking together and agreeing to do something together. So I think the future is there to have a multidisciplinary team. And in Leipzig, in fact, we have tried that for the last years, and we have achieved to work together quite well.
Yeah, so Daniela, I don't want to put you on the spot, but one of the issues that we are very concerned about in our training programs and our specialty is the gender disparity, particularly in interventional radiology. Very low percentage of women who have gone into the field. You would be a role model for women wanting to go into vascular surgery or intervention. What does the landscape look like in Europe in terms of gender within the specialty that you're in?
Well, first of all, when you start a medical school in Germany, there are a lot of female medical students, and I look then a lot of female residents, and I get to have more and more female fellows. So I think we'll. It's not easy to get there, but we'll see more women involved. It's the endovascular work, in my opinion. It's very fine, and it's very it can be very well done by women. Open vascular surgery, maybe it was a little bit not so well seen, but when you combine the techniques, I think we can do better, and I think that we'll see in the future more and more.
Well, I'm sure you're a role model. What's important is for people to see people ahead of them doing it, and it inspires them to. And
I think. I try to train my residents, and I show them it's not so difficult, in fact, and you have to simplify things.
So before we close up, I'm going to ask you the really hard questions, the ones I always hate when people ask me this question. So when you're not being a super achiever in your profession, what do you like to do to relax? I'll start with you, Erin.
Well, definitely spending time with my family. My wife is from Colorado area, and a lot of her extended family is there, so we enjoy spending time together. Getting out to the mountains is one great benefit of living in Denver, so going hiking, mountain biking, and occasionally some skiing as well.
There's kind of okay skiing.
Yeah, there's some okay skiing in
yeah.
Colorado, I've heard. So, yeah, I would say those are the major things to do when I'm outside of work.
Right. Daniela?
Well, it's like a copy-paste of what Erin said. So I enjoy being with my family. I have a daughter. She's 3 years and a half old.
Congratulations.
And thank you. And when we have time, she just take her bike and let's do a tour, Mama. And that's what we do: biking, hiking. There are some nice mountains next to Leipzig, and in winter, of course, skiing. So let's no winter without this sport. Yeah.
Well, that's awesome. So the important thing is just be normal people and spend time with your family when we're not off in Las Vegas at these meetings. So thank you, both of you, for being here. Congratulations again on your awards, and we really look forward to many great things from the both of you, and hope you enjoy this Viva Live Unscripted.
Thank you.
Thank you a lot.